So you have to put up with me for a second talk. This was Alex Tobin, who was initially scheduled. For those of you reading along in the brochure, will notice Alex was giving this talk, and he actually, could you reset the timer just to keep me on track? And Alex was good enough to share his talk with me. So some of this is from Alex's, and some of this has evolved as I put the talk together. Again, no financial disclosures. We're going to talk about neuroblastoma both from a staging and a response assessment standpoint. They're not really that new anymore, but image-defined risk factors in the IRG recommendations for both staging and response assessment in neuroblastoma I want to focus on. Neuroblastoma is important. It's the most common pediatric solid tumor outside of the CNS. It makes up about 10% of all of the pediatric tumors, and there are common sites of origin that you're all aware of, the suprarenal or adrenal region being the most common, followed by the retroperitoneum and the chest. Paraneoplastic syndromes we see as well. About 25% of the patients who present with opsoclonus myoclonus ataxia syndrome will have an occult neuroblastoma identified by imaging. So the imaging is often fairly extensive in these children, characterized by an extrarenal or adrenal mass. Fine calcifications are seen in the majority of the cases. These are characterized by the lack of a capsule and encasement of vessels, which is something we'll talk about. Interspinal extension is important, as is the routes and modes of metastatic disease spread. So you're probably all aware of the INSS classification, and the staging schema and the risk classification has evolved over many years. It began back in the 70s with the Evans staging system, which then was followed by the addition of MICAN amplification to help risk stratify. Out of that arose the INSS classification and the low, intermediate, and high risk classification. And that's where we sort of stayed for a while, and the INSS classification is one that I think most of us are aware of. And the problem with that, and this was a problem that was brought to attention by surgeons and oncologists, was that was a surgical staging system. It depended on the surgeon making a lymph node resection, and the decision about whether the patient was stage 2 or stage 3 was dependent on the surgeon. And oftentimes that was operator dependent, whether they accomplished a gross total resection. And it meant that there was no preoperative risk assessment or risk classification possible. So that led to the evolution of what are now called image-defined risk factors, which are based on imaging. They are not as well validated as the INSS staging system because they've just come into use, but it does allow a preoperative, pre-treatment risk assessment, and is one aspect of the larger INRGs, or the image, the neuroblastoma risk group classification system. The way to think about this in its very simplest term is a localized tumor that doesn't involve a vital structure and everything else, except metastatic disease. Right? So metastatic disease is its own classification. So what we're going to talk about is how we define those local, regional, or L2 tumors. Now, the image-defined risk factors are surgical risk factors. They're meant to identify by imaging factors that would influence the ability of the surgeon to accomplish a gross total resection. They influence the safety or the complexity of the surgical approach, morbidity and mortality from surgery, all of which is helpful in terms of pre-treatment stratification. The goal was also to develop a uniform reporting schema, which we couldn't do before because it was a surgical staging system, and to begin to develop prognostic factors. It is not meant to be a contraindication to surgery. Even though it's a risk factor, it's not a contraindication to surgery, nor are these absolutely definitive procedures or criteria. And they were developed by a group of radiologists. Beth was actually involved in that study that Hervé Brice put out in radiology, and Tom Montclair was a surgeon who was simultaneously involved in developing these. And out of that came this new risk group classification scheme. I don't expect you to, it's all available online, but it allowed a much more granular pre-treatment risk assessment instead of the previous INSS staging system, which was important for identifying patients who had very, very low risk of recurrence once their primary tumors were treated or resected, and those who were at high risk, so that one could appropriately assign the treatments to the different risk groups. Why was that important? It's important because when we look back and began to assign patients to those different treatment strata, the patients basically broke out into different survival categories. So certainly those with very low-risk disease had much higher event-free survival, required less therapy, less aggressive therapy, and potentially less toxic therapy, as opposed to those with high-risk disease. Now, we're going to talk about the image-defined risk factors again. This is in the radiology article. We're not going to go through these step by step, but I just want to hit some of the main points that become a little bit confusing sometimes in terms of looking at these. But before we go there, let's talk about just what the major imaging tools are for us to evaluate the child with neuroblastoma. Radiographic findings are common. This is something you've all seen. You see the right upper quadrant calcified mass with a very large corresponding calcified neuroblastoma filling the right upper quadrant. Another child who has periosteal reaction, you can see along the femur, and less obvious, but in the supraacetabular ilium, you see periosteal reaction. That prompted an ultrasound, which in turn revealed a right upper quadrant neuroblastoma. So those bone erosions, bone pain, marrow infiltration are all things that can suggest a neuroblastoma. Now the question comes up, CT or MR? If Kieran McHugh's here, I know Kieran will say MR. Don't throw away your CT scanners. He's anti-CT. CT still has a lot to offer. There are advantages. It's fast. It's easily accessible. Important for radiation treatment planning. It allows us to calculate those IDRFs, oftentimes very successfully, with faster scanning techniques, many times no sedation. Radiation's a big limitation, as is poor tissue contrast. And as I'm showing you here, all of that marrow disease you see on those MRI scans, on the MRI, these sites of marrow involvement are not seen on the CT. Now, invariably we get an MIBG scan to complete the staging, which also shows the other sites of marrow involvement. So I don't think there's one right answer, depending on your practice, but it's something that is, I think, either or are important and probably don't need both. The other thing to consider, and this is something we've been considering in our practice, is the role of CT in reducing sedation. This entire evaluation, and this is a young child, this was all done without sedation. The CT scan was done without sedation, the MIBG was done without sedation. So that whole study, the whole staging exam, we were able to accomplish with no sedation. So that's also something that has become increasingly part of the conversation. Do you need a bone scan? That's a question that keeps coming up. We keep seeing patients referred to our center with bone scans. We looked at this a few years ago. There was no instance where a bone scan upstaged the patient. The patients were, if they were stage 4, they were stage 4 for some other reason, either MIBG or a marrow. So the INRG criteria also recommend omitting a bone scan in favor of PET scan for those patients who are MIBG negative. What about PET scanning? That's another conversation. FDG PET scanning. I think for the majority of patients, we're still doing MIBG scanning. It is useful in those patients who have MIBG negative tumors. The problem with FDG is there are false positive uptake sites at sites of marrow recovery, and that's the biggest problem, making it limited in terms of evaluating stage 4 disease, and certainly for evaluating patients after treatment where marrow recovery is present for detecting marrow-based lesions. MIBG, in contrast, is our workhorse for the moment. Not great if you need to do quantitative imaging. Dotatate is something I'll show you just at the end. That's something that I think you're going to start to hear more and more about as an alternative to MIBG. And just two examples of PET versus MIBG. This is an MIBG negative patient who has multifocal FDG avid disease that was unequivocally MIBG negative. So this patient gets followed by FDG PET. In contrast, here's an MIBG positive patient with multifocal disease who has a completely negative FDG PET scan done at the time of staging. So there's no one right answer. I think we're still favoring MIBG for a lot of reasons, reserving FDG for those patients who are MIBG negative. So let's talk about IDRFs now. These are definitions. They're important because they allow you to go through that list and talk about the different IDRFs. And your job as a radiologist is to decide, are there image-defined risk factors or are there not? And then how many of them are present. So we need to talk about separation of the tumor from adjacent structures, encasement, invasion of the structures, infiltration, and compression. Those are terms that you need to be aware of. So separation is not an image-defined risk factor, and that means if there's a visible layer between the tumor and an adjacent structure like the kidney or like the liver, this is not considered an image-defined risk factor. So what the surgeon hears is the likelihood of there being surgically related morbidity is lower because there's not an IDRF. Now, in terms of distinguishing separation from invasion of an infiltration into an adjacent structure, we need to do high-quality imaging, and this is just my little pet peeve. Poor quality imaging leads to poor quality IDRF assessments, and that can be motion on an MR, that could be too low a dose on a CT, poor contrast timing, any of those. I don't think any of us would feel comfortable determining whether there's a plane of separation between the suprarenal mass and the kidney. And in fact, look at the comparison to the MIBG scan. This was contrast given on a low-dose attenuation correction CT, which is in fact of higher quality than our regular diagnostic quality CT. So we need to do high-quality imaging to help our surgeons, help our oncologists, and arrive at these IDRFs. So contact, this is also important. Contact is where there's no visible layer between the tumor and the neighboring structure. Now, in some instances, contact alone is not an IDRF. If here you've got contact against the kidney or contact against the liver, that in and of itself is not an IDRF. But if we have flattening of a vein, but you still see that the lumen of the vein, that is also, okay, the vein can be flattened, that's not considered an image-defined risk factor. However, if we have more than 50% encasement or contact with an artery, that is considered an image-defined risk factor. If there's contact with the kidney in the renal hilum, that is considered an image-defined risk factor. So contact is important depending on the structure you're looking at and the location of the structure. Encasement is a little bit easier. That's where the structure is surrounded by tumor. For vessels, the aorta or major arteries, it's a greater than 50% circumference surrounded by the tumor, or in this particular case, I couldn't show you the IVC. It starts here and it gets reconstituted here. It's completely obliterated or flattened. So this is a separate IDRF. So we have abutting the renal hilum, we have encasement of an artery, we have encasement of a renal vessel, we also have encasement of a venous structure. So we have multiple IDRFs in this patient. Now, when we talk about compression, that term compression is reserved for the airways, and it means that you've got a reduction in the short axis diameter of the major airways, trachea or proximal bronchi, and this is shown, I think, nicely here by this upper thoracic neuroblastoma. Infiltration is where the tumor begins to extend or invade into or infiltrate into a neighboring structure. In this case, we can't define a margin between the tumor and the undersurface of the liver. So that tumor is infiltrating the liver as shown by this nodular wavy surface to the liver, as opposed to those other cases where I showed you the tumor was just making contact with the liver but wasn't actually encasing the liver. And similarly here, it's encasing the renal vessels and infiltrating into the renal hilum, encasing the renal vessels here. So that's tumor infiltration. And finally, with respect to the renal pedicle, because it presents a particularly important surgical risk, meaning saving the kidney, the renal pedicle is handled separately. In contrast to the aorta and the IVC, where you can partially envelop or partially encase the aorta, any contact of tumor with the renal vessels is considered an image-defined risk factor. So that's an important thing as well. Now, what about tumors that reside in multiple compartments? Well, this is a little bit confusing, but according to the rules that have been set out for image-defined risk factors, tumors that are in multiple body compartments that are contiguous represent a single IDRF. So what we see here is this thoracoabdominal tumor that is considered one image-defined risk factor. Similarly here, we have an MIBG avid tumor that resides in both the thoracic and the upper abdominal compartment. That is considered. Now, this patient has multiple IDRFs, but this is one IDRF. The encasement of the vessels is a second IDRF. But this is not considered metastatic disease, even though it's extending into the thorax, because these are contiguous compartments. Now, that's in contrast to this particular case where The Virchow node that you see in that left supraclavicular region, that's MIBG avid, that is a separate site of lymphatic spread to a metastatic lymph node. That's considered metastatic disease. That's not a contiguous spread from the intra-abdominal primary. So that patient has M disease, not L2 disease. Okay, so these are distinctions that can be, I think, be sometimes challenging, but as you start doing this more and more, you get comfortable with it. Other special considerations: intraspinal extension of the tumor into the spine. It is considered an image-defined risk factor if greater than a third of the spinal canal is invaded, so this would qualify. If you have obliteration of the perimedullary leptomeningeal spaces, if you see abnormal signal within the spinal cord at any level, or if your tumor extends into the spinal canal at the T9 to T12 level, where the artery of Adamkowitz typically arises, those are considered image-defined risk factors, things the surgeon really needs to be aware of. So why do we care about all this? It's fairly complicated, a lot of additional work for the radiologist to be doing. Well, at least in the first few analyses that have been done, the IDRFs at diagnosis were associated with worse survival rates in one study, higher rates of operative complications. In another study that was just recently published, both of these are from surgeons, they also found an association with increased operative difficulty. In this second study, they did not find an association with overall survival. But I have to say, these were retrospective studies. These were not studies that made prospective decisions based on IDRF. So that's something that's happening and is in the works. So in terms of response assessment, just quickly, it will be a combination of anatomic and functional imaging. Dr. McHugh's group from Great Ormond Street just published a paper saying that CT is superior to MRI in the post-induction chemotherapy response assessment, probably because of calcifications and particularly in pre-surgical planning, may be preferable. And the reason in this phase, the response assessment is important for risk stratification, for assigning these patients to a post-treatment risk group based on new criteria. Now, how do we do these assessments? We talk about cross-sectional imaging, MIBG scanning. We typically use Curie scoring, both in the US and in Europe. And why do we use Curie scoring? We use Curie scoring because it's predictive. Those patients who have post-induction, meaning post-chemo, post-surgical resection Curie scores of greater than 2 have a worse outcome than those who have Curie scores of less than 2. And that means they get placed on a different post-chemotherapy treatment strata for their further treatment. And just 2 examples of patients who have Curie scores that were very high at diagnosis, and both of them converted to Curie scores of 0 post-induction chemotherapy. And both of these kids who had widespread disease are alive and well after their initial treatment. So the new IRG criteria that accompany those image-defined risk factors are equally complex. They use RECIST criteria, MIBG response criteria or PET criteria, and define patients as having complete response, partial response, a minor response, or stable disease. So we are still charged with making measurements of tumors, evaluating MIBG avidity and PET avidity in those patients who are MIBG negative. And then what I'm not showing you is bone marrow response criteria that also accompany these. Now, just in the last couple of slides, this is all becoming important, particularly for us as imagers, as we start to think about new theranostics. I-123 MIBG that we talked about is being paired with I-131 MIBG, and this, I'm showing you one example here, but this is now part of upfront treatment in a current children's oncology group study and is also being studied in Europe. We know that gallium-68 can be paired with Lutathera for neuroendocrine tumors. We also know that the type 2 somatostatin receptor is expressed on the majority of the neuroblastomas. So I think we're going to begin to see at meetings like this an increasing use of this combination for theranostic pairing in neuroblastoma. And just one example from the group Dr. Kong, who presented earlier, and Rodney Hicks, whom you all know, just one of the only studies out there looking at gallium dotatate in kids with neuroblastoma, showing new lesions or more lesions detected by this more sensitive PET imaging agent as compared to the conventional MIBG. So with that sort of a whirlwind of neuroblastoma, there's a lot going on. Staging now involves a combination of cross-sectional imaging and functional imaging. We're using IDRFs now routinely in all of the centers, both in Europe and in the US, and incorporating these into newly defined response criteria. And I think, as we talked about just at the end, there are new imaging agents that are probably going to be built into these paradigms for both diagnosis and treatment. And with that, thank you very much.